Okay, let's do the basic protocol first. Okay, so we're gonna start from the leg length test for the D field. Okay, from position. Take the friction off the table, like lift it off, and always visualize the center.
Yes.
Abhinav sir,
Abhinav.
Please mute your
Abhinav.
audio. Yeah.
So we're gonna visualize the center from the EOP, the gluteus fold, and the center of the knees to the feet. And this is the center line, okay? So we're gonna cut both feet together to the center line, and I can feel that the left side of her feet bounces off when I'm adducting the feet together. Okay, so this left side bounces back very strongly. That is a sign maybe for the C2, the axis on the left side that is bouncing back has a subluxation, posterior subluxation. Okay, so this may be a sign. Okay. If both sides are bouncing back, it's just their their hip joint or some kind of a problem with the myofascia. But if the one side is bouncing back, it's commonly posterior rotation of C2 on that side. So the left side is bouncing back. Okay, and I'm going to unlock the tension by flexing the knee joint twice over 60 degrees and bring it back. Okay, and see the leg length that the right is shorter. Okay, so this is short leg, right short leg in extension. Okay, now I want to see the deer field by flexing the knee joint at 90 degrees and see the height. And always visualize the center of the body, the EOP and the gluteal fold, in between the both ankles are in the center. But don't put these ankles together. Even in extension or flexion, these ankles should not be touching each other. It should be about 1 or 2 inches apart. And the center of those both feet should be visualized at the EOP and the gluteal fold. And I can see that in extension, right short, and flexion, right remains short. Not going beyond even, that is a sign of deer field negative. Maybe the cervical syndrome or the psoas tightness is masking all these leg length. So let's just check for the cervical syndrome first. Okay, so right short in extension, ask the patient to look to the right. Oh, you get it. So the patient looks to the right, and within 3 seconds, we have to see if the right leg gets longer, but it doesn't. So she does not have a right cervical syndrome. Okay, bring it back to neutral. Okay, now look to the left. And it remains short. So she does not have a cervical syndrome today. Okay. If she has one, we have to look for the nodule. Okay. If it's a right cervical syndrome, we'll have to find a nodule on the left side. If she has a left cervical syndrome, there will be a nodule on the right side. If there are no nodules at the cervical region, it might be a C1 lateral shear on the contralateral side of the cervical syndrome. Okay, mostly on the right. Okay, on the short leg side. So lateral shear of C1 is more than 90% on the short leg side in extension. Okay, and the posterior rotation of C2 will be on the contralateral side of the short leg. That is common. There may be exceptions. Okay? So today she looks fine because both feet are actually not so off the line. Okay. So in this case, in her case, if she was my student, if she was my patient, I wouldn't be doing any adjustment for her. I will be just doing some granular works. But she still has some tension at the hip joint here on the left side. That may be something masking these problems. And it wasn't the cervical syndrome that is masking it. So possibility of the masking might be the psoas. So I'm going to have the patient in supine position to check for or the tender points for the psoas is the toe, right? So I'm going to squeeze the toe. Okay, so okay, so she has a right psoas sign on the great toe on the right side. So I'm going to have her in a supine position. I'm going to. So the best way to examine if she has a tight psoas is doing the muscle testing. Okay. So flex 45 degrees, flexion, abduction 45, and external rotation. Stabilize the opposite pelvic and push lateral posteriorly. And this is very weak. Okay. Now I'm going to find a tender spot that will be the between the ASIS and the navel. I'm going to go deep in and find a tight spot. And this is very tight here. So in Thompson technique, I could do a drop table technique for the psoas. Okay? So the contact point will be on both sides of the psoas. The belly will be lateral to about 2 inches lateral to the navel. Okay? I'm going to pull the tissue sac up so that my pisiform here will be contacting at that level. And the drop will be very slight. Okay? I'm going to make it very weak so her body weight will drop it. Okay? Don't thrust the psoas. The drop table will do it for you. So don't thrust. Okay? I'm just going to press posteriorly as I drag it superiorly. And the drop table will do the thrust for you. Okay? Find a spot. Especially I'm contacting both sides, but my weight will be especially on the positive side, that is the right side. Okay? Come off very slowly, okay? And repeat that 3 times, 3 or 4 times. Okay? It's getting very loose. So, or if you don't have a drop table, you can use the activator at that same spot. Okay? find the ASIS, find the navel, in between that, find the tight spot, go in deeply, and then once is enough, using the activator. Now I can retest, pulse test if it gets stronger or not. Okay, the same position. It's a little bit stronger. Okay, so it was because the psoas was tight and that it may be masking the leg length in Deerfield test. Okay, I'm going to have her in a prone position again. Okay, tucked in. I'm going to have her stand up and okay, now her right leg is short. So this is the original short leg. Before doing the psoas, it wasn't so off, but now it is apparent that she has a right short leg. Now bring it to position 2 and see it is Deerfield negative. Now I have to re-examine her cervical syndrome. Okay, look to the right. It lengthens and gets longer than before. And neutral, look to the left. It stays short, so she has a right cervical syndrome. So I will be finding a nodule on the left side. Okay.
Sir,
Yes.
sir,
Yes.
sorry for interrupting. I have a doubt. So
Yes.
before you corrected her psoas,
Yes.
at that time also she had a short leg in extension and also short leg in flexion.
Yes. Yes. It was Deerfield negative, but
Yeah, even
yeah.
now it is negative, no, sir?
Yes. Yes. That is correct.
So how will we know that? I mean, again, why do we have to recheck the cervical syndrome?
Because I know that her leg on the left side in prone position, I tried to bring it into center, it bounces back.
Okay.
So, in many cases, there is a cervical syndrome on the left side.
Okay.
When I did the rotation, cervical syndrome rotation set, it was negative. Okay?
Yeah.
And
Okay.
that made me do the psoas.
Yeah.
I thought something was masking it.
Yeah.
And
So
the leg was actually not so off before
okay.
doing the job. And that is
Okay.
rare. Okay. And
Okay.
maybe that was, I thought psoas was masking it, and I released the psoas, and
Okay.
I post checked the leg length, and it was quite off. The right side was shorter than before.
Yeah. Okay. So it's only the psoas. There are other factors also masking this, no, sir?
Yes, yes.
Like
Maybe,
posterior ischium something. Am I
yeah,
right?
maybe, but most of the time, the masking of the Deerfield negative is mostly the cervical syndrome itself or the psoas.
Okay, sir. Okay.
Okay. Maybe
Thank
some
you.
problem that is rare. Okay.
Okay, sir. Thank you. Thank you.
Okay. Now I could check for her nodule. I'm going to find the spinous process of C2. I'm going lateral to that at the lamina and find if she has some. So this is C2. Go deep in. C3, 4, 5. So actually, she doesn't have anything at C2, but she has one on the left side. I'm looking for the left side because she has a right cervical syndrome, right? So she has a very tight spot nodule here at the level of C5. Okay, so to pulse examine that, I will just push to correct it as a stress pressure test. And see if the leg gets even. Okay, it gets longer. Okay? Now I'm going to do a stress test to exaggerate that rotation. So I'm going to compress the right side to exaggerate it and check. It gets very short if I exaggerate it. Okay, so that is you should do the stress test and pressure test as well. Okay. So I know that she has a posterior rotation at this nodule of C5 on the left side. So I should do a adjustment for that. Okay. Well, the original book textbook says we should stand on the positive side. Okay. And have her rotate her face to the right. Okay. So all the cervical will rotate towards the right. Okay. But the subluxated vertebrae will remain posterior. So it will be easier to locate that segment here. Okay. So in prone, her face down, I can find a nodule, but it's easier to locate it with her face rotated to the right. Begin with it. So going over here, I can find that C4 is very deep, and below C4, I can find C5 lamina rotating posteriorly. It stays posteriorly, so this is the spot I want to contact. And using my knife edge, number 8 here, pulling the tissue stack down. And before doing the adjustment, always flex the headpiece. Headpiece about 15 to 20 degrees, okay? So the weight of the patient's head, if it is flexed, it will be doing a slight traction. Okay? Contact and cup the ear and the zygomatic arch with your indifferent hand doing traction, and the adjustment will be with this left hand only. Okay, and at C5, the direction will be medial, slightly inferior. If it's upper, it's going to be towards the opposite eye. Okay? But this is C5, so it's mostly medial, slightly inferior. Okay? And the elbow should be all the way down. And the adjustment is once. Okay? Very. And back to neutral. And when you do the evaluation, the headpiece should be level again. Okay. Only when you do the adjustment, the headpiece will be.
Sir, in this position, can you do the activator? We can use this activator.
Of course, you can do anything. You could use anything. So Thompson evaluation, you could use this for any kind of techniques like Gonstead, activator, okay, anything. Okay. After adjusting, I will have to check the leg back again. Or going to anything. Bring the legs into the center. Always visualize the center and cup it and bring it to the center. Okay. And see that both legs are equal now. Okay. Now I have to reset it by flexing the knee joint over 60 degrees twice. Now, if there's anything remaining, the right leg will get short again. It's slightly short, so I have to do a cervical syndrome test again. look to the mean with it. And it gets longer again. Okay, look to the left. It remains short. So she still have a right cervical syndrome. So maybe C5 was not enough. Maybe she has something else. But after adjusting, I'm gonna find another nodule, but she doesn't have any nodules anymore. So maybe she has a C1 syndrome. Okay, left cervical syndrome. If it's a C1, there's no nodule, but if it's a left syndrome, the C1 will be translating to the right. Okay, I will do a pressure test. I'm gonna find the C1 transverse process and translate from right to left. Okay, and it gets very long. Okay, now I'm gonna do a stress test. The left atlas C1 transverse process from left to right. It gets very short. Okay, that way so I should do the recoil technique, or I could use an activator. Okay? So since Dr. Doss said, can we use an activator? Let's use an activator. Okay, and this is very effective, very specific, using an activator instead of a thrust. Okay, so I'm going to find the transverse process, pull the tissue sac down. No, I'm on the opposite side. Sorry, on the right side. Okay, I'm going to pull the tissue sac, find the transverse process, tissue sac down, and put the activator lateral to it, and the liner drive will be medial and slightly inferior. Okay, I'm gonna stabilize C2 from left to right. Okay, with my middle finger. Okay, then just come off very slowly and recheck. So the right leg is very long now. Okay. Now I could use recoil, but see that activator was enough. Okay. Now this cupping, it should be mostly of the time it is C2 syndrome, but she didn't have a C2 syndrome, but it's fixed now. Before the left side used to bounce back, but now it's not bouncing back. Sorry. Okay. Now I'm going to reset twice. The legs are leveled now, so I'm going to bring it into position 2, and it's now it is short. Okay. So in position 1, the extension position is leveled, and flex position it is not leveled. Maybe she has an occiput syndrome. Okay, bilateral cervical syndrome. It means that both sides of the occiput condyle is in AS, extension. It may be. So I'm gonna have the patient look to the right. Okay, look to the left. No, she doesn't have occiput syndrome because it remains the same. Occiput syndrome, when she looks to the right and the right leg gets short, and look to the left and the left gets short, that is a sign of an occiput syndrome. It can be bilateral cervical syndrome, but it did not respond, so I will not be doing any adjustment for the occiput. If it does, if right gets short when rotation right and left gets short when rotating to the left, I will be performing these cupping moving for the occiput bilateral like this, okay, on the occiput from extension to flexion. Let me just demonstrate. Okay. So I could just do a pressure test like this, slipping like this, or a stress test like this. Okay. So let's make it's equal now. The legs are even now, so I should do a stress test by sliding my fingers down. Okay. And the right gets, if it gets short, it's in extension. Okay. but it doesn't respond. So, she doesn't have bilateral cervical syndrome. If she does, I'm gonna flex this again, lift this up, then contact lateral inferior to the EOB on both with my thinner eminence, and just do a recoil like this, okay? So that will drop, okay? And after the adjustment, I'm gonna bring the headpiece back into neutral again. People tend to forget to bring it back into neutral. But it has to be in neutral, because if it's in flexion, maybe the dura will be pulling. Okay? So always have it neutral. So both the feet are neutral. Inflection is neutral. Okay. So I don't have to do anything for it. Okay. Okay. So if it is still short and all the cervical syndromes are cleared, and in position 2, if it is short on the right side, I could do an exception of Deerfield. Okay, so do the cervical syndrome test as we did in extension, in flexion. So right short, and look at patient looks to the right, and if the right leg gets longer, it will be a right cervical syndrome, and I will be doing just like we did for the cervical syndrome. Okay, but she doesn't have them. Now, what I can do is do a stress test for the Deerfield. Okay, so the original is slightly short now on the right, slightly. Okay, and position, flex position remains short. Yes, yes.
Can I ask one more question?
Yeah,
Yeah.
sure.
So you told me like a kind of bilateral occipital syndrome is only presented to you. Sometimes that is extension. In flexion, there can be unilateral cervical, not cervical, occipital syndrome can be a possibility. I actually know, sir.
Flexion means the occiput flexion or the knee flexion?
Occiput.
Flexion, that is a PS occiput, right? So in that way, if the legs are even right now, okay, and she looks to the right and the left gets short. She looks to the left and the right gets short. Okay, the opposite sides. Then it can be a flexion syndrome possibility of the occiput unilateral side. Exactly. Yes. Okay. Thank you, sir. Yeah. In that case, I will do. There's no drop table technique for that, so I will do a Gonstead like this. Using kind of block. Okay. And that's
sir.
Okay.
Okay. Thank you.
Okay. Now let's go to the Deerfield test. So this is the sacrum. So she had a right short leg in extension. So I want to torque the sacrum towards CW to exaggerate. And if it gets short, is a Deerfield negative on the right side. Okay. It doesn't. Okay. Maybe exaggerate again. So it remains even. Okay. So, or maybe I could do the other side. I could bring it into CW, and if the right gets long, it doesn't, or short, it doesn't change. So she doesn't have anything at the sacrum anymore. Okay. She used to, but I don't have to do it anymore. Okay. Position 2. It's still a little bit short in flexion, so there's something wrong with her. So maybe it's a posterior issue. Okay. Okay. So I could find a tight spot on the Achilles tendon, and I could squeeze it, and I think that the right side is much more thicker than left. So I'm gonna ask if this is tendon. and it's very tender. Okay, and the left side is not that tender. It's not thick, so I could squeeze it, but it's not tender. On the right side, she will jump off. So that is a sign of the right. The Achilles tendon tenderness is a sign of posterior issue, maybe. Okay, so her legs are even right now. So what I can do is to exaggerate the posterior.
Excuse me, sir.
Yes, yes.
Is that AK you're trying to explain that with the Achilles tendon
No, it's
compression?
that's Thompson.
Okay, it's in Thompson itself. Okay, sir. Thank you.
So it's on the Thompson original book. Okay. So if there's a tenderness at the great toe, it was a psoas, right? And
Yes,
if
sir.
there's tenderness at the Achilles tendon on one side, it is a posterior issue. Okay.
Of sacrum. Or PI you're trying to tell.
Issue.
Okay, posterior issue. Okay, okay.
Yeah. Okay. So her legs are even, so I don't want to do a pressure test. I will do a stress test to bring the issue back. Okay. Swinging it back.
Okay,
And
sir.
now I guess the right is very short now. Okay. Now I could post test by doing a pressure test. And it's long now. So I should be adjusting the right posterior issue. Okay. So I'm going to stand on, always stand on the positive side using your cephalad hand. Okay. Always stand on the positive side and use your upper hand with your pisiform. Okay. Contact behind the issuing process and recoil or drop. Okay. I'll just perform a recoil. Sorry. 3 times. Okay. So the right leg is long now. I'm going to flex it twice to reset. Okay. Okay. And I could pulse check the Achilles tendon. It's not that thick anymore, and I could squeeze it and check if it's it's not tender anymore. Okay. So it's tender like usual, like both sides are equal. Okay. So the thickness and the tightness of the Achilles tendon was because there was a posterior issue that is pulling the hamstring and the gastro muscle. Okay. And there's tension at the Achilles tendon because of the posterior issue. If I bring the posterior issue back to neutral, there will be no tension at the hamstring or the gastro muscles. Okay. So it will be fixed. Okay. So that is one thing. And also the leg remains short in flexion, so she has something else. Okay. So it's still Deerfield negative. It's not going to be Deerfield positive. It is still negative. So I won't be adjusting the PI ilium on the right side. Okay. And if she had a Deerfield negative, so short to short, I will have to be checking her 4 or 5 tender points for the Deerfield negative. One is the medial knee, and one is at the attachment of the hamstring at the issuing process. One will be at the PSIS, and one will be at the pubic symphysis. And one other is the contralateral medial rib, okay? About R5 or 6, about that level, because the left shoulder blade will be compensating the tilt of the sacrum. Okay. And by adjusting the tilt of the sacrum, these tender spots will disappear. Okay. If there's more than 2, it is a sign of Deerfield negative. It's an AI sacral base on this side, on the right side. But if there's no tenderness over 2, it might be a L5 rotation. Okay. So that is, if there's a short leg on the right side and it's Deerfield negative, the spinous process is always rotating towards the short leg side. If it's a Deerfield positive, the spinous process will rotate towards the contralateral side. If it's a Deerfield positive, because if the pelvic on the right side ilium posterior rotation will pull the lumbar transverse process of L5 posteriorly, like this. Okay, if it's a PI. If it is an AI sacral base on the right side, the sacral base will push the transverse process on the right side anteriorly, so the spinous process will rotate towards the short leg side. Okay, so I could do a examination here. So I'm using my chiropractic hand to see if the alignment of the spinous process is, it is actually the spinous process of L5 is actually a little bit slightly towards the right. Okay, so this is static palpation. So L5, L4 and L5. L5 is slightly rotating, spinous process rotating towards the short leg side. That is a sign of Deerfield negative. Okay. So I could do a stress test. I'm going to pull the tissue slack from left to right to do a stress test. Now it gets very short. Okay. Now I'm going to slide it, do a pressure test, slide the finger right to left. The pressure test. It gets very long. In this case, I will do I usually do a Palmer technique for this. Okay, so Palmer technique, I'll show you both. Palmer technique is using your inferior hand for L5, and above that, I use my superior hand. Okay, find this find L5 spinous process with my cephalad hand and switch hands to my corded hand. And I'm going to use my pisiform of my, I'm sorry. I should palpate with my right hand and pull the tissue slack of the spinous process from the center to the right. Okay. So I could hook the spinous process from left to right with my pisiform of my corded hand, okay, using a high arch. I could hook it like this. With PL, I will pull the tissue slack from right to left. Okay, don't pull it from right to left. Okay, left to right. I should pull it left to right. Don't pull it right to left. Okay. If I pull right to left and I contact, it will slip because there's many musculature on the right side, okay, of the spinous process. If I pull it from right to left, the muscle will be covering the spinous process. So I want to drag the tissue away, okay, from right to left. So there'll be deep lamina here. Okay, and I'm gonna be hooking with my inferior hand, okay, and using a toggle recoil. Okay, this is Palmer technique in the angle from right to left and left posterior to PDA. Okay, and the recoil will be fast. Okay. Okay, so the right leg is long now, or I could be standing on this side and doing the Thompson translation adjustment. So I will be using my superior pisiform. I'm going to pull the tissue slack from right to left and contact on the right side of the spinous process with my cephalad knife edge of my pisiform. Okay. I'm going to grab both hands with my inferior hand and my elbow should be all the way down. So I could just translate the spinous process from right to left. Okay. And a little bit anteriorly, just enough to drop the table. It should be fast. Okay. That is a Thompson technique. Okay. Both feet are, I mean, the right is actually longer than before, longer than the left, so I could just reset it. Okay. And it's actually very good now. Okay, so that is actually all for Thompson basic protocol, because the major subluxation, primary subluxation Thompson or Palmer technique will be the cervical and the pelvic. Okay. And after correcting that, both legs should be even in extension and flexion. If it is even in, we won't go further to adjust any more spine in that day, in that single day. Okay, so we have to wait for a few days to respond, and if it gets short again, we'll go on doing the major subluxation. And after doing the major subluxation of the cervical or the pelvic, we can go to lumbar. That is secondary. Okay, and or the secondary will be the lumbar and the upper thoracic. Okay, upper thoracic. And after correcting and correcting all the major and the secondary subluxation, we go to the third. That is the thoracic. And the third, the thoracic, is done. The cervical, the major, and the secondary, and the thoracic is done. We don't have to do anything for the spine anymore. We go to the peripherals. Okay, or maybe there might be a individual sacral torsion. Okay, so in that case, if the leg remains short, I'm going to ask the patient to, I'm going to stabilize the sacrum and ask her to lift their knee off the table with their knees fully extended. It's the hip joint extension. Okay, こっち上げて、こっちに足を上げて。はい、戻して。Okay, so I think it's easier to lift her left than the right. So the right has an AI sacral base. In that case, we will do, if it's a Deerfield negative, we will, in a prone, I will be doing the ischium push to bring that sacral base superiorly. And after that, I will be doing the IN portion of the Deerfield negative by pushing the ischium process from medial to lateral. That is the Deerfield negative sacral portion. Okay, and this sacral torsion, after the adjustment of Deerfield negative and the leg lifting test was positive, I'll be doing this technique to extend the positive side hip joint so I could cross her positive side leg on top of the negative side. The contact point will be on the contralateral side, medial to the PSI of the contralateral side, medial to lateral on the sacrum, not the PSIS. And on the ILA on the left side, I'm going to use my torque from lateral to medial. So my both hands will be crossing. So the sacrum will be in a torsion from CW to CCW. And do the that is not adjustment for the Deerfield negative. It's a individual AI sacral base adjustment. Only when there's difficulty of lifting the hip joint. Okay, so the right side is very long now. Okay, and there are possibilities that both sides of the hip joint is limited. Like on both sides of the knee hip joint, there's only about 1 inch off the table. So as I stabilize the sacrum and both hip joint cannot extend, that may be a sign of base P or apex P. Okay. Most of the time it is apex view. Okay. In that case,
Sir?
I'll yes.
So, the right side, on the right side, you found that she has AI sacrum.
Yes.
So you adjusted the left side, is it, sir? We could not able
Yes.
to see it actually. Okay.
Because
Okay.
if there's a torsion at the sacrum, okay, so the sacrum is side bending to the right because there's an
Okay.
open wedge on the right side, and
Yeah.
the right sacral is anterior. That means that the left ILA is posterior superior.
Yeah.
So I
Okay.
want to bring the sacrum. This is in clockwise. I want to bring it back to neutral. As I
Okay.
contact mostly on the ILA on the left side.
Okay.
This will flip the right sacral base posteriorly.
Okay.
And this hand will be on always on the contralateral, both hands on the contralateral side to
Contralateral side.
torque it. So the right side will go superiorly. I'm contacting on the left side to fix the right side.
Yeah. Okay.
Okay.
Yeah. Thank you, sir.
Okay. So that is one adjustment. And usually that will be enough for the basic protocol. Okay. For the above, for the lumbars, I will be doing the palpation like this and find misalignment of the spinous process, some tenderness maybe. And for the lumbar, from L1 to L5, if I feel some swelling, edema, and misalignment of spinous process, I will be doing a stress test or pressure test and doing the adjustment just like I did for L5. Okay. And after that, I could go to the upper thoracic and do the same thing. Same thing. That is the secondary subluxation. After the secondary, I could go to the thoracic remaining. But in the same visit of adjusting the diaphragm negative or positive, I will not be adjusting the thoracic. Never. Until it is fixed. Okay. Now, for the exceptions, I can find maybe the right side has a IN, remaining IN ileum or a EX ileum, or right and left. I could do just a pressure test or stress test. If it's IN, I'll bring it laterally for stress test, or medially for EX. And I can do it in both sides. Nothing responds, so she doesn't have any IN/EX on either sides. Okay. I could do that to the issue. Okay. I could pull the issue medially and see, or laterally. Nothing. Okay. So the others, I can see if she has tenderness at the rib angle on the left side, contralateral side of the short leg. I think she does have. So here, what did I get here? This is R4. It's very rare. It's usually 5 or 6, but she has one here. So this, I thought it was a compensation of the short leg on the right side, but this remains after the adjustment. So I can do an adjustment for this. Okay. The original adjustment in Thompson technique is in supine position. I'm looking at this. And it's the left side, so I'll be standing on the left side. I'm going to use my thinner eminence on that rib angle of R4. It's as I contact on her anterior side with my inferior hand, like this. Make a sandwich and thrust this way. So the anterior hand will be adjusting it superiorly, as the posterior hand will be anteriorly thrust, okay, using the drop. Okay. So if she's a female, she could be covering her breast like this, lifting this up. Right. So R5 with my thenar eminence, R4 there, and the adjustment with my pisiform under R4 on the anterior side, and adjustment will be okay. And that is for the what compensated rib, rotated rib. And also, what can we do? That is all, I guess. If she has a superior rotated rib, like if the shoulders are compensating, okay, like if there's a pelvic tilt, like and Deerfield negative on the right side, it will be like this, right? So the shoulder will be like this. So maybe the ribs are elevating on the right side and descending on the left side. So I will be doing adjustment like this. Okay. So she has a short leg on the right side. So right side may be elevating. So I could palpate it. Most of the time there will be a tender point at the rib anterior right midline of the clavicle and above R3 or maybe sometime R2. Okay, so I think she does have a tender spot here. What do you type? Okay, this is tender, and I can feel that the right side is a little bit anterior and superior, okay, than the left side. So I'll be using the drop table at the chest, contacting with my thenar eminence here. She could cover her breast like this, a female. Okay. And this left hand will be the lower rib, okay, lower rib on the contralateral side. So I could bring the right side down and the left side up. Okay. Breathe in, breathe out. Too strong. Breathe in, breathe out. Once is enough. Okay. And after that, I could check if the tender spot disappears. Mashi? It doesn't, it's not that painful anymore. Okay. Okay, that is the elevated ribs or rotated ribs. Okay. What else? Well, that's about it for the what I usually do for Thompson basics. Okay. Okay. Any questions? That's good.
Sir, can you also please show us for PI ilium correction that you do?
Okay, sure. So let's just show you a sample of Deerfield positive, right?
Yes, sir.
Okay. So let's say she has a Deerfield positive on the right side. So I'm going to have the patient in a supine position and doing the arm fossa test, okay, with the right hand. Sorry. I'm gonna use the anterior deltoid muscle and do the muscle testing, okay? So I'm gonna find the inguinal ligament, okay? And at the inferior portion, if I push the inguinal ligament medially, that will bring the pubic bone anteriorly. Okay? And that it will be upper boot subluxation if the arm fossa gets weak. If I contact on the upper fibers of the ligament and push it medially, the ilium will rotate posteriorly. And that is a sign of a lower boot subluxation. Okay, so I have to compare. So this is a lower fiber and the upper fiber. So the upper fiber is slightly stronger. Okay. She doesn't have a Deerfield positive, but still, if I contact on the lower and press it medially, the pubic bone is a little bit, maybe slightly superior. Okay. In that case, she has a PI ilium, but it's an upper boot subluxation. It's PI, it's the ilium is rotating PI, but the PSI is slightly rotating posteriorly, and more the pubic is anterior superior. So I will be contacting on the pubic, on the inguinal ligament, where the muscle testing spot was very gets weak. I'm going to contact that ligament from S to I. Okay, and I could do a adjustment on the ligament. Okay, on the ligament. So I'm gonna, the ligament will push the pubic bone inferiorly and posteriorly. Because if she has a Deerfield negative or positive, the pubic symphysis will be very tender because it's one of the tender points. I can have her touch her pubic symphysis with her finger, and so I could be slightly off lateral on the positive side of her fingers with my Pisces fork. Okay, on above this inguinal ligament on the right side to force it down. Okay, with a torque, like torque it down. That is posterior ilium, PI ilium, Deerfield positive, but it's a upper boot subluxation. If it's a lower boot subluxation, the PSIS will be rotated posteriorly. So I could, the response of that will be if I push the upper fibers of the inguinal ligaments medially and the deltoid muscle gets weak, it will be a lower boot subluxation. Okay, and in that case, I will have the patient in a prone position. Okay.
So for this, the one correction that you did,
Yes.
the line of drive is to the opposite side.
Yeah.
Mhm.
On the textbook it says inferiorly,
Okay.
but I rather do it a little bit slightly towards the opposite feet.
Yeah.
Oh,
Yeah.
okay. Slightly.
Yeah.
Okay.
Yeah. Okay.
That is good. Yeah. Okay. So for PI ilium, I can stand on either side, but I rather stand on the contralateral side of the PI. Okay. So I lift the piece, contact below the PSIS with my superior hand, pull the tissue sac up, contact very slightly with my high arch. So I could push the PSIS superior and anterior with a torque like this. So my hand will be PI, so bringing the PI into AS. As I do that, I'm going to use my number 8 behind the ischium process on the contralateral side and thrust with both hands, but like 70% with my contact hand and indifferent hands 30%. It's going to be very fast. Okay? I'm going to lift it up and thrust. Okay? And repeat that 3 to 4 times. Okay, that is a PI adjustment. Okay, But she doesn't have a Deerfield positive. So I should not have done that. It's just a sample. Okay? It doesn't have to be strong, even if it is positive. Okay. The drop table will do it for you. It's better to do it lighter. Okay. It is much more effective to do it lighter, okay, than doing it strong. Okay. All the mistakes that chiropractic does, and if it doesn't work, it is because it is too strong. Okay, so there are datas using mild technique is much more effective using the muscle testing, leg length test, or the X-ray analysis. Okay, so the mistakes are always too much force. Okay, not enough force. Okay, not enough force. So people tends to think that it is too weak. Okay, but that's not the problem. It's because it's too strong. They're moving other components along with the adjustment, so it's not effective enough in X-ray either. Okay. The softer you do it, the thrust, it has to be fast. It has to be fast, but not strong. Okay. Maybe it's too strong or too slow. Okay. Okay. So, Dr. Das does activate is much effective than a stronger thrust. Okay. Okay. Namaste. You guys good?
Namaste, sir.
Namaste, sir.
So,
Any other?
Namaste. Namaste.
yeah,
Am I-
sir, one last question. Sorry.
Yeah, sure. Don't worry.
Sir, for this PI ilium, we can also do correction in the supine position as well, no, sir?
PI in a supine position. Supine ilium in a supine position.
Yeah, they'll do one adjustment with the ischium and on the ASIS. Is that for PI or something else? PI.
In a Thompson technique?
Yes, sir. Yes, Thompson.
No.
It's a Thompson book. I saw
Yeah.
it.
In a supine position for a PI ilium, did you say?
Yeah, in supine position, we'll do it for PI ilium or what? I'm not really sure. Is it for PI ilium or posterior?
I don't know. I haven't seen that. I never seen that. Which book is that? The
No,
the
yeah, sir, in Deerfield negative, the patients
oh, Deerfield negative. You mean
yes,
AI sacral base? Yeah, I can do
yeah,
that in a position.
yeah,
Okay.
yes,
Let me show you that.
yeah.
So there are always two steps for Deerfield negative. Okay.
Okay.
One is to lift the inferior sacral base. Okay. So in this case, I'm standing on the right side. But if she has a Deerfield negative on the right,
Yeah,
to lift the sacral base superiorly, I'm going to flex the hip
yeah,
joint
same thing.
into 60 degrees and the knee joint into 90 degrees. Okay.
Okay.
And contact with my number 8
Yeah.
under the ischium process here with my knuckle. I'm
Yeah.
going to stabilize the ASIS, and the adjustment is with my inferior hand superiorly.
Mm.
So this is the inferior portion of AI sacral base.
Okay, yeah. Yeah.
This is number 1. And the second portion of that adjustment will be fixing the IN. Okay. So in this case, I'm going to flex the contralateral knee hip joint, stabilize it. Okay. And for the IN means that it is flared out. So I want to use the inguinal ligament to bring it into flare in. So I'm going to contact on the inguinal ligament lateral to it and torque it medially to bring the ASIS medially. If I bring it medially, the PSIS will go IN to EX, okay?
Okay.
So this will be very light, using very torque, like,
Okay.
get it? Okay.
Yeah. Yeah.
So there in supine or prone position, we're doing the same routine. Contact point is different, but the routine is the same. Get it?
Yeah. Yeah. Thank you, sir.
Good. Yeah. Okay. Any other questions?
Sir, in C1 toggle recoil,
Yeah.
if it is on symptomatic on the right side, so we place the hand on the right side or onto the left side.
If there's a cervical syndrome and the patient looks to the short leg is right, okay, and the
Yeah, yeah.
patient to the right, and the leg gets even, that is a right cervical syndrome. So we contact on the left side. That will be
Yeah.
very
So activator, we do it on the right side.
no on the left side.
No, sir. In the like what you have demonstrated, when you have done C1 left to, sir, right to left, leg
Yeah.
got shortened. So you
Right.
use the activator onto the right side.
Yeah. There is
So toggle recoil also the same side, or
she had a left cervical syndrome.
okay.
So
Yeah.
left cervical syndrome, she looks the left and the right gets longer. So left
Okay.
syndrome means that the positive side will be on the right.
Yeah.
Okay. So I contact on the superior short leg side. It's mostly the atlas will translate toward the short leg side, and
Yeah.
C will rotate posteriorly on the contralateral long leg side. That is
Yes.
common. So I contact on C1 on the short leg side and adjusted it immediately.
Yes, and now my question is for toggle recoil. Now,
Yeah.
do I place my hand as activator being placed or under
Yeah.
the opposite side?
On the same place.
Okay,
So
say on the right side on.
on the right
Yes.
side. Usually is
Okay.
activator or recoil. Either.
Okay. Because
Okay.
I thought it like when we do a bounce back, what I felt was it would trigger up more.
It doesn't bounce back. By
Okay.
bouncing back, recoil, it will be putting it specifically in like we did, like this. I show you these toys exactly like this. So the C1 is translated to the right. So I'm going to do a recoil like this. Okay. It will be specific. Okay. It's
Okay.
not gonna bounce back like this.
Okay.
Don't worry. So it's the same spot, same line of drive. Use it toggle recoil or activator or a thrust. Okay.
Yes. And can we use it with a pillow to keep the neck in neutral?
Yes. So
A soft or a firm one? Which
if you
one would be?
do you have a drop table?
No, sir, I don't have it.
Oh, okay. Well, you don't have a drop piece, cervical drop piece.
No, sir.
So you should
संदीप भाई ड्रॉप पीस ले लेना इस बार
Ah,
use these drop.
या फिर ऑर्डर कर लेना
Yeah, these. I took these. This is from Dr. Omkar. I took this cervical headpiece off and put this cushion on. So
okay.
I could use it in a prone position or side posture, C1. So this is very decent price and the quality is very good. Okay, so
Okay.
I have the patient in a side posture, right side up, mingi wingi stick. Okay. And put this in. I could lift it up and use her head weight so it will drop. loosen it. Lift it up, contact on the right side. Muscle gold. I could either stand on the anterior side or the opposite side. I could find the transverse process. As I did, I could do it in a side posture. I could use the activator, the contact, and adjust it medially like this, medially and slightly inferiorly, like this. Okay, come off. Or in the same direction, I could use a drop. Okay. Well, it's too soft, but I could just make it like, okay, it's the same direction.
Okay, sir.
And if you have a drop table and a drop piece, but the inside posture, if this does not elevate it, I use these pillows on the drop piece and lift this drop piece up and do the recoil kick. So the head will be level in the side posture.
Yeah.
If this is not on, she'll be bending like this. Okay. I put a pillow so I could do the recoil.
Okay.
Using the drop. Or you don't have to use a drop. If you have a straight table and if it doesn't drop, you can use these pillows as well and do a recoil without the drop. Okay.
Okay, sir.
Okay. So
Yeah,
if you
yeah.
want, you should buy these kind of pillows where there's hole here. So the ear will
Yeah.
be in here. Okay. This will stabilize C2. So it will be stabilizing C2. You know what I mean? Like if you want to adjust the right C1 here, this will be like here. So this will be in the arch of the cervical, and this hole will be at the ear. So C1 will move medially without C2 moving medially.
Okay.
When you do the recoil or the thrust. So it's supposed to be like this, but I use it this way to stabilize the cervical with this pillow.
Okay.
So these are, you can get these very cheap at massage shops or anything. So, or take it off your massage table and use it.
Yes.
Okay.
And so one more doubt, if you don't mind.
Yeah, sure.
When we should consider Lovett reactor, is it on the first sitting or on the second or third sitting? Because Lovett reactor,
I can't hear what.
sir, when should we consider regarding the repeated subluxation Lovett reactor which you have shared us?
I love it.
Yeah. Is it on the first sitting or onto the start from first sitting itself or from second or third sitting? When should we consider?
We should start it from the start. We should use that as an evaluation tool for the whole spine.
Okay.
Okay. So when you, if you're going to adjust L5, that is corresponding to C1.
Yes.
If you adjust C1, you should check L5.
Yeah.
If you adjust the C2, you should check L4 as well. If you adjusted L4, you should see C2. That's the level.
Okay.
We use that all the time.
Okay.
Okay, all the time, from the start to the end. It's a tool.
Okay. Yeah.
For every-
Because like most of the time when we correct the sacrum itself, we see there is no symptom shown in the cervical region, like what we have done in osteopathy
But
initially. Okay.
But still, if you fix the sacrum, there's a core link between the occiput.
Okay. Yeah, yeah.
Love it. It's like a love it.
Yes.
Core link. Okay. So after adjusting the sacrum, I always go to the occiput.
Okay.
If I go to the occiput, I will always go to the sphenoid.
Okay.
So we're gonna discuss more about the advanced technique in the next visit, but we're gonna do a coccyx, and we did something to the sphenoid, did we? Remember? Did we or not?
No, sir.
In activated techniques, if you adjust this coccyx, you always have to adjust the sphenoid. Okay,
You
so
mean sphenoid, you said us of about the craniosacral therapy,
No.
like CST during osteopathy, right?
I'll demonstrate that in the next module. Okay, and
Okay.
practice. If I adjust the coccyx with the activator, I always find the sphenoid in extension, the superior, and drive it down with the activator inferiorly.
Okay.
Okay. Well, we'll talk about that later on in the course. Okay, when we
Okay.
meet in Mumbai.
Yeah.
And that's very effective.
Sir, Sandeep sir is coming to Japan, not Mumbai.
Oh, really?
Yes.
You are? Well, that's great.
Yeah.
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 We'll have fun here.
Sure.
Okay. Okay. That's about it for today. Okay.
Yes, yes. How are you, sir? How's your health?
I'm fine, thank you. Yeah,
Yeah.
how about you? You good?
Yes, 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 sir.
Yeah, because today I see a lot of good friends. I'm feeling much better. Okay.
Yeah, have a great day.
Looking forward to see you either in Mumbai or Japan. Okay. See you soon. Okay. And
Yes,
before
sir.
Thank you, sir.
before the offline in Mumbai, maybe we could gather this online again if anybody has any doubts. Okay. Just request me
Yes, sir.
anytime. Okay.
Okay, sir.
Goodbye. Take it
Goodbye,
easy.
sir. Bye.
Thank you, sir. Thank you, ma'am.
Thank you, sir.
Bye, sir. Thank you,
Bye,
sir.
sir.
Thank you, ma'am.
Bye.
Bye-bye.
Bye, ma'am.